A very good evening and a warm welcome to one and all present here. I am Debulina from Clinic. We are very much proud to be a part of this webinar as a digital partner. So now with all of you, I am going to share a short glimpse of Clinic. Clinic is India's largest live digital CME and doctors generated medical content platform. So now here is a short glimpse of Clinic for all of you. Thank you so much, all the doctors, for your patience. You all are invited to visit our website, which is www.clinic.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors only. That also you can read. Besides, we have polls and quiz that also you can play in your leisure time. So now, without further delay, I'd like to hand over the session to Dr. Hamida Mustafa ma'am to start with our today's scientific program. Over to you, ma'am.
Thank you, Debalina. Good evening and a very warm welcome to all. I'm Hamida Mustafa, doing my pre-final year MBBS in Government Thiruvarur Medical College and State Coordinator of SNO Tamil Nadu. I feel really elated to see medical students from across this nation have joined this webinar. IME has been doing plethora of webinars on various topics with the objective of keeping the medical community informed. The patrons of our webinar are Dr. Abul Hassan sir, a well-acclaimed pediatric surgeon from Erode. Sir is the chairperson of IME in Tamil Nadu and also the IME team State President-elect 2024. IME in collaboration with SNO Tamil Nadu under the guidance of Dr. Abul Hassan sir presents the webinar on the topic, How Did Your Life Begin? A Journey Through the Human Embryonic Period, Part 2. I feel honored to introduce today's speaker, Dr. Stephen Frank sir, MD DNB Anatomy, postdoctoral fellowship in cytogenetics. He did all his courses in CMC Vellore. He served in the Department of Anatomy at CMC Vellore for 8 long years. Then he served as an AP at the Vellore Medical College and AP at Madras Medical College. Now he is a senior assistant professor at Government OT Medical College, the Nilgiris. Without wasting much time, I request Dr. Stephen Frank sir to take over the session. Welcome, sir.
Thank you for those kind words, Hamida. And yes, welcome once again. Can I start sharing the screen now?
Yes, sir.
All right. So today we're going to do a second part of our class on the embryonic period. And this period is from week 3 to week 8. And this is known as the period of embryonic period, or the period where organogenesis occurs. So in this period, the 3 germ layers that we are used to become specific tissues and organs. So that's what happens in this period. All right. By the end of this embryonic period, the embryo actually has a recognizable shape, has a recognizable form, and many of the organs have already been developed. So that's interesting, right? So by the end of 8 weeks of your life, everything that makes you is already developed. And after that is just growth. So I find that very exciting. Okay, going back to week 3, we ended week 3 with the ending of gastrulation, with the formation of notochord and the beginning of neurulation. So we're going to see in the following few minutes what else happens after the end of 3rd week. We also saw about the placenta, where the placenta developed tertiary villi by day 21. All right, so let's start with neurulation. So at the beginning of 3rd week, we saw that the ectoderm became a neuroectoderm, and neuroectoderm became so thick that it had to fall down and become a groove, and the folds come together and a neural tube is formed. And when the neural tube is completely formed, you can see this red color cells escaping. These are nothing but the neural crest cells. And these neural crest cells have a fantastic reach in our body, okay? So finally, if you want to understand where your brain and spinal cord came from, it actually came from ectoderm. So the neural tube is like this. It has a cranial neuropore and a caudal neuropore. And until these neuropores are open, the neurulation is not complete. And only when they're closed, we say neurulation is complete. And so the cranial neuropore, or the one on top, or the anterior neuropore, closes by day 25, and caudal neuropore closes by day 27. Now, in the brackets, I've written 18 to 20 somite stage and 25 somite stage, because until this time, we start measuring the age of the fetus, or we start understanding the age of the fetus by the number of somites it has. So this is when the caudal neuropore closes. That's by the end of 4th week, day 27. That is when we say neurulation is complete. The neurulation actually, like I said, gives rise to your brain and spinal cord. The brain keeps on expanding, or the cranial part keeps on expanding and having ventricles inside it. That becomes your brain. And the caudal part remains narrow, and that forms the spinal cord. All right, I told you about the neural crest. Actually, essentially, when the neural folding is occurring, this fold part, or the apex of the fold, is actually specialized cells called the neural crest cells. And they migrate into this layer, and this layer is nothing but the mesoderm. So they migrate into mesoderm, and everywhere you can think of something interesting happening in development, that's because of neural crest cells. So just an example to show you where all neural crest cells can migrate. They migrate to everywhere where mesoderm can play a very important role. And so I have a list here. Let's go through the list. Let's see what else, something that we've never thought of. We'll see whether it's coming up here. So first, the connective tissue and the bones of the face and skull, and as well as the skin, dermis of the face and the neck. Then in the region of the head and neck, it also gives rise to odontoblasts, rest of the skin, melanocytes. Then when you go to the heart, the conotruncal septum of the heart is derived from neural crest, even the adrenal medulla. And then you have all this nervous parts, because that is cranial nerve ganglia, dorsal root ganglia, sympathetic chain, and the pre-aortic ganglia, and the parasympathetic ganglia of the GIT. Then you have supporting cells of the nervous system, like Schwann cells, glial cells, even leptomeninges, all are derived from neural crest cells. The neural crest cells have a very wide range or wide reach, if we consider how small or how interesting this cell is. One more thing before we go on to differentiation of the mesoderm, that the neural crest cells can be from anywhere in the neural tube, can be from the cranial neuropore end till the caudal neuropore end, can be from anywhere. And specific areas of neural crest cells migrate to specific organs. Like, for example, the ones in the upper thoracic and lower cervical region of neural crest cells migrate to form the conotruncal septum of the heart. That means, I'm trying to say, the migration of neural crest cells may be normal elsewhere, but at a certain somite level or certain somite area, if the neural crest cells don't migrate well, that specific organ is affected. It's not that all the neural crest cell derived structures can be affected. But if you find one neural crest cell defect, then we have to actually actively look for other neural crest cell defects. Going on to differentiation of mesoderm. Well, mesoderm is formed as a layer, okay? This is called intraembryonic mesoderm, all that is highlighted in green. And now this mesoderm starts differentiating into mesoderm closest to the notochord. Then you have an intermediate mesoderm, and then you have a lateral plate mesoderm. So I tell my students, when you want to remember it, remember paraxial mesoderm like this, because that's going to form somites, and that gives rise to muscles, so something like that. Then when intermediate mesoderm, remember it like this, because intermediate mesoderm gives rise to all the genitourinary structures. Then the lateral plate mesoderm, remember it like this, because it divides into two layers again with a cavity in the middle. So that's how we say the divisions of intraembryonic mesoderm. First, let's consider the first bit, or the most medial part, or the paraxial mesoderm. I mentioned that word somites. Somites is nothing but these balloon-like or bulb-like structures on either side of the neural tube, and that is because of the differentiation of paraxial mesoderm. So paraxial mucidum divides into cubical segments called somites, and they first appear in the cranial part, and they continue to appear in caudally and continue to appear cranially also, but appears first near the neck region. The somatomeres of the head region contribute to mesenchyma. The head from the occipital region, the somatomeres are now called somites. The first somite is seen on day 20. So if you see the appearance of this first cubical structure, we say that the age of the embryo is day 20. All right. Then many somites continue to appear, and about 3 somites per day. And at the end of week 5, we have 42 or 44, anywhere between them, that many somites. So somites, what are somites again? They are representation of paraxial mesoderm. And the first one appears by day 20, and then 3 per day till the end of week 5. So if you see how many somites are there, we like to classify them: 4 in the occipital region, 8 in the cervical, 12 thoracic, lumbar, 12 thoracic, 5 lumbar and sacral, and around 10 coccygeal pairs. And I said the age of the embryo is determined by the number of somites it has, because this is more specific than you can, if the mother is not sure about the history, and if you have seen the first somite, that means you are seeing day 20. All right, let's go on. The first occipital and the last 5 coccygeal somites disappear. They form and they disappear. You will see this trend happening in embryology: formation, disappearing. So this is the first occurrence when it actually, when a part of mesoderm, which is completely differentiated as a somite, appears and then disappears. The first occipital one and the last 5 or 7 coccygeal ones. All right, so if we have a neural tube like this and notochord like this, and we call this area or this cubical orientation as a somite, the somite starts to differentiate, or align into different parts within itself. And if you see the cross section of it, it becomes like it has a triangular orientation. The ventromedial part is called the sclerotome, and the dorsolateral part is called the dermatomyotome. Okay, so this is the sclerotome. So what does sclerotome give rise to? The sclerotome, actually, this part, you can see that this part it just starts going around the notochord, They surround the neural tube, notochord, and give rise to the vertebral column and the ribs. So sclerotome, it gives rise to vertebral column and ribs. So that means the vertebral column, the formation nerve of the vertebral column in itself is interesting, because one vertebra does not come from one somite, but it comes from adjacent somites. But now we know that the sclerotome is responsible for the formation of the vertebra and the vertebral column and the ribs. The other part is called the dermatomyotome, and the dermatomyotome divides into 2 layers again: the outer dermatome, because it's supposed to be closer to the skin, that's going to be the outer part, and the inner myotome layer. So you can see now how the dermatome and the myotome are, kind of differentiating and more developing into dermatome giving rise to the dermis and the subcutaneous tissue of the entire body. Whereas the myotome is what is responsible for the skeletal muscle of the limb, of the body wall, and any area of skeletal muscle, it comes from myotome. All right, so that is why we have dermatome. The name dermatome means the area of skin supplied by one spinal segment. So that's why this segmental nerve supply is established here. But if the myotome decides to migrate, it will pull its nerve supply. For example, the diaphragm, the thoraco-abdominal diaphragm, is actually a myotome that is in the neck region. And then it migrated down. Even though it migrated down, it pulled its nerve supply. That's why the diaphragm is supplied by the phrenic nerve C3, 4, 5. All right, let's go on. Cranial to the first cervical somites, we have occipital somites. And the occipital somites actually structures that develop in the back of your neck, and they migrate to where the tongue lies, because the tongue musculature is derived from the occipital somites. So when we see the cranial cavity or the cranial skull, we see all the foramina are either opening anteriorly or opening towards the inferior aspect. But we see the hypoglossal canal or hypoglossal nerve exiting posteriorly, and that's because it actually supplied the occipital somites, but the occipital somites migrated and formed the tongue. Then we also have something called pre-occipital or the pre-otic somites, and they are supplied by 3, 4, and 6 cranial nerves, and so they are the extraocular muscles. Well, at this time, we have the formation of an interesting cavity inside of the mesoderm, and we call that the intraembryonic coelom. Intraembryonic coelom. So this cavity is actually a horseshoe-shaped cavity. This picture, I'm just going to orient you for a while. We're actually sitting in the amniotic cavity, or we're standing on the ectoderm. With the mesoderm is below us, and the endoderm is much into the screen. So we're standing on the ectoderm and looking down, and you can see that in the mesoderm, this kind of cavity is developing. This, for orientation, this is the buccopharyngeal membrane, and this slit here is the cloacal membrane. And you can see now the neural tube and the somites that are forming either side of it. And this cavity develops, that's called intraembryonic coelom. You can see that their cavity actually has 2 halves, but is continuous and cranial to the buccopharyngeal membrane. Yeah, so that continuity is there. So this is the cavity. This pink, the cavity inside the pink highlighted area, that's the cavity of the intraembryonic coelom. After some time, this cavity opens out. Can you see that? Here it's opening out, and it's continuous with the extraembryonic coelom cavity, or which we now know as a chorionic cavity. So an intraembryonic coelom is now communicating very freely with the extraembryonic coelom, like so. So I was showing you only this central part of the picture. Now, if you go on to the peripheral part, you can understand this is the chorionic cavity. This is the yolk sac cavity. This is the amniotic cavity. And this cavity is the intraembryonic coelom. And the intraembryonic coelom is now continuous with the extraembryonic coelom, or the chorionic cavity. And this part is where this mesoderm is connected to the mesoderm here. That's called the connecting stop. All right. Now, the lateral mesoderm, lateral plate mesoderm. So this was the somite, the triangular cross section. We're not going to talk about this. We'll talk about it a little later. This is the intermediate mesoderm, and now we're talking about the lateral plate mesoderm. Remember, I told you lateral plate mesoderm like this because it's got a cavity, and that cavity's name is intraembryonic coelom, and that divides the lateral plate mesoderm into 2 layers. The layer on top is called the somatopleuric layer because that's going along with the ectoderm. This is ectoderm. It's going along with the ectoderm. This is also ectoderm here. It's going along with the ectoderm. It's called somatopleuric layer because skin. And this layer that goes along with the endoderm, so this dark line here is endoderm. This layer is going to form or going to be the mesoderm of this around the endoderm covering. That's going to be called the splanchno-pleuric or the visceral layer of the intraembryonic mesoderm. So now we have 4 divisions of mesoderm. We have somite, and somite divides into sclerotome and dermatome and myotome. And then we have intermediate mesoderm, and then we have 2 layers of lateral plate mesoderm. The layer that goes towards the ectoderm is called somatopleuric or the parietal layer, and the layer that goes with the endoderm is called the splanchno-pleuric or the visceral layer. Just a different orientation of the same thing. We're going to see this somewhat showing a 3D understanding of the same thing. This is the notochord. This round structure here is a somite. You can see the somites forming like that. This is the intermediate, there's a paraxial mesoderm, intermediate mesoderm. This is the lateral plate mesoderm dividing into 2 layers. The layer that's going up, this orange layer or the red layer here is called the somatopleuric layer, and this layer is going along with the yellow. This orange layer is called the splanchno-pleuric layer. All right. You can quiz yourselves on this slide later, all right? Okay. The intraembryonic coelom gives rise to all the cavities inside our body, that is pericardial cavity, pleural cavity, and the peritoneal cavity. We forgot, we paused at the intermediate mesoderm, and now I'm telling you that forms the urogenital structures. So now we know that the somite forms sclerotome, which is responsible for forming the vertebra and the ribs. The dermatome forms the dermis and the subcutaneous tissue, and the myotome forms all skeletal muscles. Intermediate mesoderm here forms the urogenital structures, and the lateral plate mesoderm forms the mesodermal structures along this ectoderm and along the endoderm. So I just want to quickly talk about summarize what we've done so far. That is neurulation, the neural crest derivatives, and the differentiation of mesoderm. Neurulation begins in the third week or begins towards the end of third week, and it finishes by the end of fourth week. And its finishing date is day 27, 28. That is when the caudal neuropore closes. All right. Continuing on, there's going to be folding of the embryo. Okay, so now the embryo is, after all these cavities are formed, that is when the embryo is ready for folding. Now you're asking me, why does the embryo need to fold? Till now we have seen a flat disc-like embryo. We're standing in the ectoderm, we're standing in the amniotic cavity, remember? Where our feet were on the ectoderm, there was mesoderm and endoderm below it. And so it has got a very flat disc-like or a slipper-shaped appearance. Now that has to fold, and that folding occurs in two steps. All right. Before we understand folding, let's talk about this yellow line. This yellow line is nothing but the endoderm lining. So in this picture is very interesting. The blue is ectoderm, and this yellow is endoderm, and intervening mesoderm is somewhere there. Okay, anyway. Okay, so this endoderm lines this cavity, and this cavity is called yolk sac cavity. And this cavity is called the amniotic cavity, and the cavity outside here is called the extra embryonic coelom, also called the chorionic cavity. All right, and in the picture to show you the same thing, you can see now that this is the yolk sac cavity, that's the amniotic cavity, and here we have the chorionic cavity. Well, the first folding is called the cephalocaudal folding. Now, for the cephalocaudal folding, if you can remember, if you can imagine yourself when you listen to this lecture, if you can imagine your head also bending and your tail also coming, that is called cephalocaudal folding. Head and tail bending is called cephalocaudal folding. And this is because of the movement of fluid within the cavities, within this embryonic, within the yolk sac cavity and the amniotic cavity. You see now that the yolk sac cavity kind of pushes the embryonic disc into the amniotic cavity, and the amniotic cavity fluid kind of runs on either side, kind of pressing it to fold in the cephalocaudal folding. So we have the head fold. This is the region of the head fold. Sorry, the arrow is a little displaced. This is the region of the tail fold. And by the end of this cephalocaudal folding, we have this kind of orientation, not from a flat disc, but a slightly curved disc like this. All right. If you see it, if you see the other folding, that's called lateral folding. Now you can understand now in this orientation that the cephalocaudal folding is not seen, but the two lateral ends of the flat disc-like embryo comes together in the anterior aspect, and that is called the lateral folding. So this is also showing you lateral folding. This orientation different from the previous pictures. Here again, we can see the amniotic cavity, yolk sac cavity, and the cephalocaudal folding may have occurred. We can't see it on this picture, but now can you see that the amniotic fluid kind of falls down on each side, bringing the two lateral ends together and resulting in the formation of what we now know as the primitive gut tube. Okay, so this is endoderm, and this mesoderm around it is called splanchnopluric or visceral mesoderm, visceral layer of lateral plate mesoderm. I'm sorry for the long nomenclature, but that's what it is. And you can see that how when this lateral folding occurs, this is going to pinch off and form the primitive gut tube. This is what is called the primitive gut tube. The primitive gut tube also has three parts: foregut, midgut, and hindgut. The foregut is the part from this membrane, that is the buccopharyngeal membrane, up to the opening of the yolk sac, that's called the foregut. And the opened part of the endoderm to the yolk sac, that part is going to be formed, that's going to be called the midgut. And the part caudal to it is going to be called the hindgut. All right. So the midgut is the one that communicates with the yolk sac, and that communication channel is called the vitelline duct or the vitello-intestinal duct. So the other names are omphalomesenteric duct or even yolk stop. All right. So that's how the primitive gut tube is formed. This is after cephalocaudal folding and after lateral folding. And the yolk sac kind of gets, almost pinched off, and that's why it looks like a small balloon. I'm sorry. And that is called the umbilical vesicle. Okay, so these are the series of steps for cephalocaudal folding, and also at the same time, lateral folding is also occurring like this, and that results in the formation of primitive gut tube. Okay, so this is the primitive gut tube. This is the part of the gut tube that is not opened out to the yolk sac. This is the part of the gut tube that is opened out into the yolk sac. Because this must be midgut, and this must be either foregut or hindgut. So that's how it's going to be. So what do we have at the cephalocaudal end, and that's called the buccopharyngeal membrane. Now this, in the 4th week, this ruptures and opens the communication between amniotic cavity and the primitive gut tube. Okay, now you should understand by now, I should have guessed it by now, that the buccopharyngeal membrane is going to be somewhere in the mouth. And when that opens up, the amniotic fluid can go inside the gut tube. So that's what happens if you know what a fetus will be lying and drinking its own amniotic fluid. So that's how this occurs in the 4th week. This rupture occurs in the 4th week. And this hindgut is bound by a membrane here called the cloacal membrane. And this breaks down by the 7th week. And that's how it opens up into for the anus and the urogenital orifices. All right. If you can see now that the embryo is expanding, like, can you make out a small blue layer is now become a thick blue layer. So it's kind of expanding, and the cavities also are expanding, and the amniotic cavity is expanded most. All right, amniotic cavity is expanded most, and the yolk sac cavity is become very minimal. So we can say now that the embryo is floating in the amniotic cavity. All right, embryo is floating in the amniotic cavity. So the same picture from a different book, you can make out this red lined cavity is the amniotic cavity. This blue dotted line is the yolk sac cavity, and how the yolk sac cavity is almost pinched off, almost become like a small a vesicle, whereas the amniotic cavity is expanded. Amniotic cavity expanded. All right. Now, this was the connecting stalk, right? This was the connecting stalk. See how the connecting stalk also starts to migrate. It was on the side first, nowhere close to yolk sac. But as the folding occurs, it makes sure that the connecting stalk is in line with the vitelline duct, is in line with the umbilical vesicle. And so that's very interesting, because that gives the way for the formation of the physiological herniation, right? So this is what's going to happen. All right, so now we know you already understand this, the epithelial lining of most of the GI tract is endodermal in origin. Even the lungs, because lungs are diverticulum or foregut, even they are endodermal in origin. What are the other endodermal derivatives? We have parenchyma of the thyroid, parathyroid, liver, pancreas. Liver and pancreas are glandular structure having parenchyma and stroma. Parenchyma is from endoderm, whereas stroma in any gland is from the surrounding mesoderm. Also, we have stroma of the tonsils, of the thymus. We have epithelial lining of the urinary bladder, urethra, middle cavity, auditory tube. All these are endodermal derivatives. What are the ectodermal derivatives for now? The surface ectoderm now covers the entire embryo. You can see this blue layer was the surface ectoderm. And when it expanded, like when the lateral folding completed, it's going to cover the entire body wall. So surface ectoderm gives rise to the skin, right? And that is now covering the entire ectoderm. So what are the other derivatives? Anything in contact with the outside world. So we have central nervous system, peripheral nervous system, all the sensations, all the sensory epithelia of the ear, nose, and throat. So they all come from ectoderm, but specifically what ectoderm is neuroectoderm. And the other ectodermal structures, even glands, epidermis, enamel of teeth, that comes from the ectoderm called surface ectoderm. Right, we come to the mesoderm now. The paraxial mesoderm is giving rise to somites. We know somites form vertebra, ribs, dermis, subcutaneous skeletal muscle. Intermediate mesoderm gives rise to urogenital structures. And lateral plate mesoderm gives rise to two layers, the splanchnopleuric and the somatopleuric. The somatopleuric is all the mesodermal structures related to the skin. So here we have, wherever the ectoderm is, so it goes close to that, and it forms all the mesodermal structures related there. and also all the lining of the peritoneal, pleural, and pericardial cavities, because that's the cavity, just intraembryonic cilium is lying just next to it. And the lateral plate is lying just next to it. And whereas the visceral layer forms the endoderm, membranes of all the organs like visceral pleura, visceral pericardium, and visceral peritoneum. Okay, now we have blood vessels also developing in this time. The blood vessels develop in two ways. One is called vasculogenesis, and the other step is called the angiogenesis. Vascular genesis is how a vessel is just formed by islands of blood coming together. Angiogenesis is from that one vessel that is already formed, how new vessels grow out. Okay. Okay, so it's going to, those are the two steps of formation. But how do these blood islands come about? So blood islands are seen in the mesoderm, every mesoderm by third week. What do I mean by any mesoderm, every mesoderm? There is, remember, there's extra embryonic mesoderm. In that as well, blood islands develop. And in the intraembryonic mesoderm also, blood islands develop, all right? So first they appear in the yolk sac. You can see this is the lining of the yolk. So this is nothing but the extra embryonic. And then later on only they develop in the lateral plate. So vasculogenesis. So these mesodermal cells, because of a factor called FGF2 or fibroblast growth factor 2, they are modified into a special cell called the hemangioblast. And this is a precursor cell, and this gives rise to either two things can happen. So hemangioblasts, if they're in the center of the island, they become blood stem cells or blood cells. If they're in the periphery of the island, they become blood vessel cells, angioblasts, and form blood vessels. So this vasculogenesis is first the formation of hemangioblasts by a factor, by a protein, by a gene called FGF2. Then after the hemangioblasts form, depends on where they are in space. If they're in the center of the island, they form the blood cell. If they're in the periphery of the island, they form blood vessels, something like this. These are just random mesodermal cells. Once their fibroblastic growth factor 2 acts on it, they develop into this beautiful stellate shaped cells. If the cells in the center, they form hematopoietic stem cells. The cells in the periphery, they form the vessel cells. So that's how the primary vascular bed is formed. Now, additional vessels are added by angiogenesis. That is derived by that's mediated by vascular endothelial growth factor. So that's how the blood vessels develop in two stages. All right. We're going to talk about the next part. It's called the position of the heart, because by the folding up that is occurring, the heart also has to be immediately set in its correct place. Why am I talking about the heart suddenly? What about the other organs in our body? Well, the heart is now already being formed. Already there is some tubing already coming together and forming the heart tube. So that's the first organ to develop. So the first organ to be set in its place has to be the heart. All right, remember this picture? We said this was the cavity called intraembryonic coelom, having two limbs connected by here. This is cranial to the buccopharyngeal membrane. And this connecting part is going to give rise to the pericardial cavity. All right, this connecting part is giving rise to the pericardial cavity. Okay, a different orientation of the same thing. This was the this was the intraembryonic coelom that is going to give rise to the pericardial cavity. The splanchnopluric layer just adjacent to this is going to be what we call as cardiogenic area or the cardiogenic plate, because in this mesoderm only, the vasculogenesis, angiogenesis, when it comes together, forms the heart. This part. So if I go back to the previous picture, you can't really make out where that splanchnopluric layer is. But do you understand, right? This intraembryonic coelom divided the lateral plate mesoderm into two layers, a splanchnopluric and a somatopluric. The splanchnopluric related to this area is going to form the cardiogenic area. Like, for example, this is the cavity, this is a splanchnopluric, that is a somatopluric, And this continuation of somatopluric splanchnic is specialized mesoderm called the septum transversum. This is a specialized mesoderm called septum transversum, the continuation of somatopluric and splanchnopluric. And this splanchnopluric part of mesoderm that is, adjacent to the intramedullary cilium, the fused part, that gives rise to cardiogenic area or cardiogenic plate, or gives rise to the future heart tube. And I just talked about septum transversum. This is the unsplit mesoderm in the body, and that has got a very specialized function, gives rise to so many interesting structures. And one of them is the stroma of the liver, diaphragm, anterior abdominal wall, and so on, septum transversum. In this picture, can you locate that structure? So this was the angiogenic cluster, or the heart tube forming. All right, that's the heart tube forming. And that white space is actually the pericardial cavity. The white space is actually the pericardial cavity. And see how it, how the heart tube, this stomach-like structure, is lying within this heart tube, lying within the pericardial cavity. So if I want to say where the situation is, this, I'm sorry for being this picture being so tiny, but can you make out this connection here, or this gap between the blue and the brown? That is the buccopharyngeal membrane. So first, I can say confidently that the pericardial cavity and the heart was cranial to the buccopharyngeal membrane. If you want to imagine it 3D on your face, if this was the buccopharyngeal membrane, the heart and the pericardial cavity are cranial to it. And as the cephalocaudal folding occurs, that becomes caudal to the buccopharyngeal membrane. Can you see that? Can you see that? Can you see it in this picture? When the buccopharyngeal membrane is now become cranial, and the pericardial cavity in the heart tube has become caudal. So the establishment or the positioning of the heart is depends entirely on the cephalocaudal folding. Well, how does the heart look? How does the body or the fetus look externally during the second month? Like this. You can see that these are the somites. You can actually start counting them to see how many somites they are. You can see this is the end of the 4th week. The somites are there. At the same time, there are balloons here, the balloons here. These are actually limb buds, limb buds. And these balloons here are called the pharyngeal arches. Pharyngeal arches. Pharyngeal arches is very interesting understanding of a ectoderm, endoderm, and a core of mesoderm coming to form a curved arch-like structure on the neck and the lower face. Those are the pharyngeal arches. Here also, I told you, they can see the limbs, you can see the face, the eyes, the ears, the nose developing, and the head also increases in size. You can see that the head also increases in size, right? And so the end of this period, at the end of 8 weeks, you have the embryo that is completely folded. You have all the 3 germ layers established into what they're going to become. Blood vessels in the heart is in place, and the external appearance actually looks recognizable than a disc-like structure. That's the end of my first part. Can you give me a minute? I'll set up the second part, please. All right. The rest of the development is actually called fetal period. Now, until now, we talked about the baby or the fetus from day 1 to the end of 8 weeks. Now, from 8 weeks onwards, some books will say 10 weeks onwards, because they want that 6 to 10 weeks of physiological herniation, they want to consider it as embryonic period. So let's say whatever it is, 8 week or 10 week onwards is the fetal period. Fetal period. So today, in this rest of the few minutes that I have, I'm going to talk about what is fetal period, what is teratology, and what is the importance of prenatal diagnosis. All right, so fetal period begins by the 9th week and up to the birth. I said it's debatable, but let's say end of 8th week, that is early 9th week onwards till birth, is fetal period. And that this period is when maturation occurs. The development or the genesis has already happened, and now only maturation and growth of the body occurs. All right, the first thing in the fetal period is interesting because we can estimate the fetal age And there are certain ways to estimate. We know these are the terms that these terms I'm not going to go through because you know just the meaning of these terms. Well, we have a 40-week pregnancy, we call normal, 37 we call premature, very premature is less than 32, and extremely premature is less than 28. All right, estimation of fetal age. In the first trimester, we use the crown rump length to estimate the fetal age. Crown length is method of choice because there's little variability in fetal size during this period. All right. Also, we call this sitting height, but it's not necessarily sitting because the gluteal and the lower limbs are not yet developed. All right, and this is how crown and rump length progresses exponentially as weeks go by. And we have this Carnegie's and also this very famous pictures you see where the crown rump length of a 9-week fetus and how the exponential increase occurs of the crown rump length. The second and third trimester, we use the biparietal diameter for actually telling the fetal size or even the head circumference. These are other tools are the abdominal circumference, femur length, and the foot length. And if you've gone to the clinics, you would have already seen how an obstetrician or a sonologist uses all these measurements and comes to an estimated fetal age, estimated fetal weight. The other height, the length of the fetus, you can also continue to use crown rump length, also the crown heel length. The growth in length is particularly obvious in the third, fourth, and fifth month. And growth in weight or increase in weight is evident in the last few months. So you can see as weeks after fertilization go by, the length is first and then the weight is later. And you can see that, suddenly the weight only increases. All right, 40 weeks is measured from the last menstrual period or 266 days after fertilization or 38 weeks after fertilization. Month-wise, we'll go month-wise. If you realize in the first week of life, we studied the embryo day-wise. Then we went at week 2 and week 3, we did it week-wise. Now, because there's not much happening, only growth happens, we're going to study it month-wise. Okay, so let's talk about the crown rump length. In the third month, the head circumference is, so much, and its proportion to the height is almost half the height of the fetus. But as you go by, as the development occurs, you can see that it becomes smaller and smaller. So third month fetus is what we already discussed because that is what we ended at the embryonic period, and it has a very human-like appearance. And if you can see in these pictures, the eyes were directed laterally, and now they come more ventrally, and the ears, which were a little lower down, come up in the definitive position. The limbs also, which were very short and stubby, start to grow and look proportionate to the rest of the body. And this phenomenon of umbilical herniation occurs. It begins by 6th week and ends by 10th week. We all know what that is. And this herniation is responsible for the orientation of your gut in adult. That means the rotation of a gut occurs in the herniated bowel, and that's very interesting. Okay, so by 10th week, it gets back. By 12 weeks, we have the appearance of all these ossification centers. External genitalia also develop, so we can estimate the sex by the ultrasound. And muscular activity develops, so the quickening is felt by the mother. In the 4th and 5th months, the fetus grows very rapidly. The crown rump length by the 20th week is 15 centimeters. And then this interesting structure called the lanugo appears. This is a fine hair that is seen in the fetus, and it's almost like it's blonde or transparent. It's called the downy hair, and that actually falls off as the child grows. And the 5th month is when even the muscular activity developed earlier, the mother can feel it only by the 5th month. The 6th month is when the second half of intrauterine life, or we can say the next trimester has started, and the fetal growth is very much so. You can see, but if a child born at that age, that week, that month, you can see the skin is very reddish, almost transparent. All the internal structures and organs are still seen. The respiratory system, the central nervous system is not developed sufficiently, and such a baby has very low chance of surviving. Seventh month, the baby is now 1.1 gram, and the organ systems are much better differentiated. And if it's born now, still there's a 90% chance of surviving. 8 and 9 months, that's towards the term, the fetus has well-rounded contours because of good deposition of fat and the presence of this white pasty structure called the vernix caseosa. That is actually a product of the sebaceous glands. The skin sebaceous glands secrete a lot of sebum, kind of protecting the skin from the surrounding amniotic fluid, and that is vernix caseosa. And then by the end of ninth month, the skull has the largest circumference, more than the shoulders, and that is the first thing that comes out through the birth canal, and that is kind of makes this way for the rest of the body to just come out. Normal birth weight, we all know, is about 4 kilos, or anyway from 2.5 to 4. Normal birth height is 50 centimeters. And most fetuses are born within 10 to 14 days of their calculated EDD. If it's born a little earlier, we say premature, little later, we say post-mature. So what are the factors influencing fetal growth? We have maternal factors, fetal factors, environmental factors. What are the maternal factors? Maternal disease like diabetes, hypertension, genetic, any other vascular disease, infection like rubella, smoking, alcohol, even malnutrition of the mother can gravely affect the fetus growth. What are the fetal causes? If the placenta is not established well, if there's more than one pregnancy, all that can be fetal causes. Environmental causes, external injury like by drugs or radiation, environmental causes. Some of the genetic factors that we know, we have studied, we understand them are numerical aberrations and structural aberrations. Well, these are the ones that we know of. There are many that are underlying and many that are, occult and not, developing into a disease. But the numerical ones, why am I saying spheric? The numerical ones are polyploidy, monosomy, and trisomy. The structural ones are deletions, duplications, and translocations. So the study of teratology is basically a science that studies all these congenital malformations in the fetus because of maternal, fetal, or environmental effects. And the birth defects or congenital malformation can be, there are two terms used to describe the structural, behavioral, functional, and metabolic disorders present at birth. So that these defects or these abnormalities are divided into 3 types. One is malformations. Means is not formed properly. Like for example, in this case, I'm showing a picture of a ventricular septal defect, where it's not formed. The interventricular septum is not formed. Those types are called malformation, and this is because usually when there is something happening in the early embryonic period or the organogenesis period, 3rd to 8th week of life. Then we have abnormalities called disruption, means the early part is fine, but because of, like, for example, in this picture is showing amniotic constriction bands that gave rise to, destructive processes that can cause disruption in the normal growth. So there's malformation, there's disruptions, and there's deformations. This is because of mechanical forces. Like there's a picture of CTEV or congenital talipes equinovarus. This is because of mechanical forces on the fetus for a prolonged period of time. They can have a deformation. So you have malformation, disruption, deformation. And now if there is something similar fitting for all the features that you examine or all the features that are there, we call it a syndrome. A group of anomalies that occur together having a specific cause. For example, let's say somebody has an extra chromosome 21 in each of their cells. They'll have a certain phenotypic jargon that fits into one, like you have simian crease, you have Down slanting, as you know, I'm talking about Down syndrome, right? So that is a syndrome. Then you have association. Then they're not really related, but they are non-random and they occur very frequently together. That's called association. In future, if you can determine why they are occurring together, probably you can call it a syndrome. All right, this is an example of the Down syndrome. I told you there are many things that can occur in Down syndrome, and that is because of trisomy 21, a genetic defect. Then this is an example of an association. If somebody has a vertebral abnormality, you have to look for anal because they usually occur together. You can even look for cardiac. You should look for tracheoesophageal. You should look for renal, limb abnormalities because usually they occur together. There's not a specific syndrome they fit into, but they occur together. This is a cause of rubella in the mother causing congenital cataract, can cause glaucoma, can cause heart defects, deafness, malformed teeth, all because of rubella. All right. Then we have, you know this picture, this is thalidomide causing amelia and meromelia in babies because thalidomide is a wonder drug given for nausea in early pregnancy, and that caused this defect. If the mother takes alcohol, there's something called fetal alcohol syndrome that the children can develop, and these are the features. I'm not going into it. I'm just telling you there's a broad spectrum of disorders we consider under teratology. Folic acid deficiency causes neural tube defects. This is a severe form called anencephaly, where the cranial neuropore does not close at all and the brain doesn't even develop. This is a much still severe, but milder than the anencephaly. This is called the meningocele or the meningomyelocele. How is it prevented? Well, first, nutrition supplementation. That's the obvious thing. That's why the government is all on, full on into this, supplementing every pregnant mother, even in the pregnant age group mothers also, females also are given. Then placing a woman with certain diseases under special metabolic control, avoidance of alcohol, drugs in all stages of pregnancy, avoiding having children in advanced maternal age because that can result in genetic diseases like disorders like Down syndrome. After all this, how do we want to diagnose children or fetuses? That's called prenatal diagnosis. If there is a problem we already know has occurred, we want to diagnose them. We can diagnose them by prenatal diagnosis. And the most common we all know and is more very routine now is the ultrasonography. The other more slightly invasive ones are maternal serum screening. More invasive is amniocentesis, and even more is chorionic villus sampling. All right, so this is ultrasound. This picture you're very familiar with. It's non-invasive, it's safe. It's just by bouncing high-frequency sound waves. It can be done abdominally or vaginally. And you can pick up a lot of congenital malformations. You can estimate fetal age, and you can estimate the amount of amniotic fluid and condition of placenta as well. See here, the multiple pregnancy also is picked up. Maternal serum is for certain special things like AFP, human gonadotropin, estriol, and the results of that can be judged into or can be used for diagnosis of what's going on inside. Then we have an invasive procedure called amniocentesis. You can see that this is an ultrasound guided procedure. You have an ultrasound probe there and a needle with a cannula that can aspirate some of the amniotic fluid to send it for genetic diagnosis. Now, what do you see in amniocentesis? Why are we just using amniotic fluid? Isn't this just fluid? Well, this fluid has desquamated surface cells of the embryo. And that's very interesting because just by that, you can actually make these desquamated cells even to stimulate them even mildly, and they will multiply like crazy. And you can pick up any genetic abnormality there. A more invasive one is the chorionic villus sampling, and you can see that they're using again an ultrasound guided procedure. You can either do it from the abdominal side, or you can do it from the vaginal side, and they take a pinch of the chorionic villus or a pinch of the placenta to see what's happening in the fetal side. This one has a lot of you can have a lot of maternal contamination because of chorionic villus sampling. Well, that brings us to the end of my talk. I hope you've understood. We talked about embryogenesis, and we talked about the development of all the organs, the development, the fate of many of the layers, the ectoderm, endoderm, mesoderm. And then we went on to talk about what happens in the fetal period from the 9th week or the end of 8th week till birth. We zoomed past it month-wise. Thank you so much. Over to you, Hamida.
Good evening, everyone. Honorable Speaker Dr. Stephen Frank, sir, and all the participants. It is such an honor for me to get the opportunity to thank you all on behalf of SNO Tamil Nadu. I would like to express my gratitude to esteemed delegates of this webinar for their presence and contribution to make the webinar a great success. I extend my gratitude to our honorable speaker, Dr. Stephen Frank, to take out time from his busy schedule to grace the event and pass on the knowledge to us. Thank you for inspiring and encouraging us with your words, sir. I must thank Dr. Abul Hassan sir and Venkatesh sir for their constant support and organizing team for working hard to make this webinar successful. Thank you, everyone.
Thank you.